Hello, everyone. Welcome to our webinar today with Mingle Health. I'm Charles Howes, the VP of Marketing here. We're excited to dive into attribution, outcomes, and revenue, tools for alternative payment models to engage your patients, but also increase your payments. Before we get started, I just want to give you all a quick introduction to Mingle Health for those of you who don't know us well. Since 2012, we've been a qualified registry for Medicare, helping folks with PQRS, meaningful use, and now MIPS and the quality payment program in particular. But big picture, we really seek to be your partner in the transition to value-based care, helping you improve outcomes, save time, and increase earnings. And we like to do this through a unique combination of technology and expertise through our consultative services. Those of you who have worked with us know that we like to assign a dedicated, knowledgeable, friendly, what we call a consultant, to each of our clients to guide them through the program that they're participating in and help spot opportunities for improvement, areas where you might want to look ahead in the future, and really helping you succeed with the programs, avoid penalty, and maximize those incentives. A few logistics before we get started today. This webinar is being recorded. The slides and recording will be sent out by email later this week. You're also encouraged to ask questions throughout the webinar using the chat question box with the system. Go ahead and take a moment to get your screens organized. We do have a slide share, but also we've got video here since we are all accustomed to that remote work environment now. One of the perks of this really challenging year. We do want to take a moment just to say thank you to all the frontline healthcare workers who are making it possible for folks to be vaccinated, keeping people well, and responding to the global pandemic that continues to, really be a challenge that we're all rising to overcome, and yet we can all only each do our part. So thank you. All right. We're excited to go ahead and jump into the presentation. I would like to introduce my colleague, Roxanne Thacker. She is the VP of Managed Clinical Services here at Mingle Health. She has decades of care management experience. I'm not trying to age you, Roxanne, but it is amazing to hear about the work that you've done with practices and patients in this unique way of interfacing with them to really help them feel more connected to their care and achieve those better outcomes for each of them. She's also a board certified pharmacist. So she's decided she liked patients so much that she wanted to really be in this unique role of working with practices, providers, and patients at this intersection, building care management programs. So she's our expert on primary care first, and today we're going to share the success, really a case study of one of our practices that we support in the program and what they've been able to achieve with their attribution and their payments and their engaging with their patients. So over to you, Roxanne.
Fantastic. Thank you so much, Charles. I have to admit, yes, decades of experience does seem to feel a little painful, but today I'm excited to talk about an advanced payment model. There are several out there in the value-based care world. I've interfaced with several different programs. Primary Care First is the CMS program right now that we're specifically focused on, but certainly the attribution methodology that I'm going to talk about is applicable to any program where you are having patients attributed or assigned to your practice. And then you're responsible for, maybe it's a cost measure, maybe it's an outcomes measure, maybe it's a preventive health measure. So what method is this madness? Like, what is the method? What is the methodology? What does that look like? Wait, who is attributed? What patients are missing? That is our biggest challenge across value-based care. Is we're providing care for a whole bunch of patients, and that care is outstanding, but we're not getting credit for those patients. And the next thing is, well, what kind of service might be needed? Are there patients who need a little more attention, or are there patients who need less attention? How do we identify those? It's always difficult to keep track of people in healthcare. So often we lose people through the cracks of healthcare, and we really want to try to, as much as we can, prevent that from happening. And then, of course, I really want to focus on your questions. What are the challenges that you're seeing? What are the opportunities? What are the successes that you're having? Because we learn a lot, both from failing and from succeeding. So I'm excited to hear from you. Feel free. I'm pretty open as a person, so I'd love to hear from you as well.
I can attest to that. Before we jump in, we do have a quick poll. We wanted to hear from folks of, is your organization currently participating or considering, you can think of it as considering or currently, an alternative payment model. So we'll go ahead and launch that here. And if folks could take a moment, please, to select all that apply. It'll help give us the context of what programs to keep in mind as we go through the presentations. All right, we'll give it about 10 more seconds. All right, thank you. So let's go ahead and pop that up for us all. So we've got folks in the MSSP, CPC Plus, several folks in Primary Care First, and some other programs as well. Feel free to pop into the chat if you don't mind the other programs that you're participating in. We'd love to hear, have those in mind as we're going through. And then several folks who are not quite sure or it's not applicable given your role. So thank you for taking that time. And now let's go ahead and dive in.
Fantastic. Thanks so much. And thank you for sharing what is happening in your practices. It helps me to understand what additional things I need to speak to, and it helps me to prepare a little bit for next time too. So I wanted to share the start of our case study. It's a primary care practice, 13 providers, 1,200 patients, plus or minus, of course. They have a fantastic team, and the practice is growing, was growing really fast. Many of their patients are homebound. 80% of the visits are with Medicare beneficiaries, so they really are a geriatrics practice. They decided on new enrollment in an APM. That APM happens to be Primary Care First. The alternative payment model uses CCM, or chronic care management, and annual wellness visits, or plurality over the previous 24 months. Well, if a practice is growing quickly, you're adding patients quickly, but you don't have 24 months of history with them. The question became, well, how do we figure out who the fee-for-service patients are versus the PCF patients? So, you know, what are we going to do? We also wanted to make sure that patients were getting great care, regardless of whether they were fee-for-service in the APM or another insurer, right? We wanted to be insurance agnostic as much as possible. And their EMR didn't quickly identify attributed patients. When you get a list of 600, 400 patients, it's really not reasonable to do each patient individually, put some sort of note or pop-up, and there just wasn't a way to interface well. So definitely some challenges, but at the same time, really a great practice and some great people working there. So for the purposes of Primary Care First, the patient can self-attribute. Chronic care management delivery helps to get the patient attributed, and I can speak to that more specifically at the end if you'd like. Annual wellness visits, either the first-time wellness visit or successive years. Again, I mentioned plurality of care and a 24-month look back. Again, if you're adding patients or you have a somewhat transient population, that can be really, really difficult. And then patients get attributed with essentially a 90-day lag to the end of each quarter. So AWVs completed through December 31st wouldn't show up as in attribution until the beginning of the second quarter. So there is some lag. That's pretty common across most programs, but what that lag is seems to vary a little bit. One important note that I just popped up, current CMS data indicates about 70% of patients across the nation are attributed appropriately. That means 30% are not. If you're matching the trend, that's a lot of patients that aren't attached to the right provider. And that does a couple of things. Definitely impacts your financial bottom line, but it also affects your quality, because patients who are doing really well, or patients who are not doing well, we're just not paying attention or getting the right information across the board. So what does an attribution tool need to do? I have often said I can open a window with a hammer, but it is probably not the best option. So we need to figure out what is the best tool. How can we start to identify what it needs? First, it needs to be quick. It needs to be a tool that's efficient. And we need to be able to see changes quickly as well. We need to see if the patient's eligible for any attribution services, whether that be annual wellness visits, chronic care management. Maybe there's another attribution methodology that other programs are using. You want to be able to predict and monitor some of the financial results. And in the IT world, my change to Mingle was a big challenge because, I came from a primary practice role. And so EHRs and learning new EHRs has been definitely an uphill battle, because everything is saved in different places, or it's, hidden in this field over here, or you have to dig into this menu 3 steps deep. So we really need something that's easy to use, that really allows the user some intuitive, gives them an intuitive tool that they can see, oh, well, it looks like if I want to see a patient, I'm going to click there. We need to be sure that we have the person running the process, not the process running the person. So sometimes when we get too much technology, it becomes the process running the person, and that just makes people irritated generally. And then we need to be able to follow up, monitor progress. I have a firm belief in quality improvement, and you haven't succeeded until you failed at least a couple of times. And so you need to know what isn't working to know what you can make work. So it's really important to monitor that progress and then adjust your plan based on whether that progress is what you're expecting or whether it's really not having much of an impact, especially as you think about how much effort you're putting into something. So here's a couple of screenshots from a tool that we're using and that is specific to Mingle Health. It's a tool that I've been working with for quite some time. Obviously, you can see that I've grayed out some patient information, so you can see at least what the screens are going to look like. So first, we need to be able to select for preventive services if that's the attribution methodology that we're needing. So you can see annual wellness visits in this list. For primary care first, one of the measures of success is also colorectal cancer screening. And so that might be another one that you need to check into. You need to see, when did you last check? My favorite story is cute little lady I was immunizing, and she wanted a flu shot. Was great. Was, January. And when I said, when did you get your last flu shot? She said, well, I got it 2 weeks ago. I mean, obviously she didn't need another one, but she was convinced that she did because she really wanted to be protected. So we need to know, when did we last check? When did we last ask that question? We also want to know, are they eligible for the service? So often we can provide a service, or we say everybody needs this service, but we only get paid for a fraction of the work that we've done. Well, if we know in advance whether we're going to get paid for a service or not, or whether they need that service, I think that's incredibly helpful. Next, eligibility. So if they're not eligible now, when will they be eligible? How do I schedule that? How do I plan for that? How do I plan for that patient? And lastly, particularly for purposes of this discussion, is the patient attributed? So you can see on that third line down there, you can see bone mass measurements. No, the patient is not attributed. Then it allows me to ask a whole lot of other questions about what's happening, what do we need to do, what needs to change, and what does that look like? So on this particular screen, again, you can see I'm looking specifically at annual wellness visits. Again, the third one down says they're not attributed, but they're also not eligible for the services yet. So it doesn't make sense for me to just start working on my not attributed patients and just randomly, hoping that I can shotgun the right set of patients. So really important to kind of have all of those pieces tucked together, and then make sure that my team understands what to do with that information. So in a lot of the advanced payment methodologies, new patient lists are released on some sort of cadence. In Primary Care First, that cadence is quarterly. And so we have to be able to identify active versus inactive patients, right? How do we get that information? We need to be able to search and sort. We need to be able to update the attributed list in the system. Maybe it's not in your EHR because there isn't a good method to do that. And then anticipating some of the care needs. Are they going to need a pneumovax? Have they had one? And yes, the initial inputs can be a little bit cumbersome, just because it just takes time. But at the same time, if someone is looking year over year, or we're looking back at your performance for quality measurement, it's really important that we see what's happening. And you can use the tool however you want. Again, a hammer will open a window. May not be the method you want, but it depends. Do you care if the window is there in the future? Again, maximizing staff time and effort. It doesn't make sense for one of your front desk people to spend 2 weeks making phone calls to patients to try to get them scheduled if you don't know if patients are eligible for services. Or maybe it makes sense that you set up some sort of, once the patient has had a new patient visit, when they're checking out, maybe the next thing that happens is they get an annual wellness visit. Setting up some protocols and some simple things to make sure that you have a process that works and that is streamlined, and thinking about that in advance, not kind of after the fact, is incredibly helpful. So I also know, having been in primary care, every patient has different needs. Without a question, every patient has different needs. And because of those different needs, they need to be treated differently. We can't put them all in the same bucket. Sure would be easier, but we can't do that. This is an example of tasks specific to a patient. So this patient needs some additional services, but it may be that every patient doesn't need everything. So this allows you to kind of pick and choose. If you're really focusing on alcohol misuse screening, that may be something that you want to do outside of an annual wellness visit. We know, based on some more recent studies, that through this public health emergency, a lot of older adults particularly are inappropriately using alcohol and other drugs. And so I think we need to start talking about what are the consequences of this pandemic, in addition to the disease itself, but what other things are we seeing? When we socially isolate people, what happens? What do we need to do to combat that? And how do we bring people back? How do we bring them back into our medical practices? How do we bring them back from whatever lifestyle habits that they had through the pandemic? I also read a study recently that said that people were getting more personal time, but they weren't exercising more through the pandemic. I found that particularly interesting. I found that I needed to be out of my house walking. I don't know if anybody else did, but I needed to take a break from having everybody right around me. So I was probably one of the very small number of people who were exercising more than before. So the practice that I'm going to share with you, they're called primary care house calls. They are the 13 nurse practitioners that I referenced previously, providing in-home care in the panhandle of Florida. And we may have Marianne with us. I'm not sure. I can't see through all of the names. So they do have a lot of new patients. Again, they were struggling to be financially viable in fee-for-service. It's just really hard to run a house calls kind of practice. They had a new AWV program. It was doing okay, but there wasn't a really great uniform or universally delivered methodology. All of the nurse practitioners kind of do their own thing. They're all fantastic, but there just wasn't a set way to do things. And just like most of us in healthcare, we're a little technology challenged, some to a greater extent than others. What do we need to do? How do we access this or that? And how do we utilize the tools that we have to the very best of their ability? So this slide has a lot of numbers on it. I want to kind of help explain what's happening here. So before we got really involved with supporting them, in the first 6 months of 2020, they had completed 107 AWVs. Not bad, not horrible, but it allowed us to see what kind of attribution effect those AWVs and plurality of care would have. So at their acceptance into primary care first, they were at 378 patients attributed, which they are a group 4 practice. It ended up equating to what we estimated was about $200,000 per quarter. So 1,200 patients, this isn't looking particularly helpful across their whole population. In quarter 1, we had been working on AWVs for that quarter 3 in the previous year. We were able to get 134 annual wellness visits done. So numbers are coming up. They had a provider who wanted some extra job, extra money, and so she started working on annual wellness visits specifically. So getting those additional annual wellness visits in contributed a lot to their attribution improvement. So the first quarter, they added almost 150 patients, which really increased their quarterly revenue. And as a result, that last column is the difference multiplied by 4. So across those 4 quarters in the year. So pretty significant. $300,000 across the year is nothing to sneeze at. I would take that home. That would be fine. Quarter 2, we really pushed hard through the end of the year. And we were able to get 271 annual wellness visits done. And that again gave us a big bump in attribution. So, now we're at 690. That's 312 from where we started. Again, big dollars, big differences. And the other thing is these patients are getting great care. We're paying attention to their advanced care planning. We're paying attention to whether they're getting their flu shots and whether they're getting their pneumovax or pneumococcal vaccines. We're paying attention to whether they really should have a colonoscopy or really whether that doesn't make sense to them. We're looking at all of those preventive care kinds of things that are super important. We're looking at their fall risk, right? That's part of the annual wellness visit. So all of those things are contributing to us as providers recognizing what are the potential problems. What are the things that are coming that we could do something about now to make sure that we're not, we're not dealing with that later just because we overlooked it. So again, that annual wellness visit allows you to look at things separate from their disease process and kind of see the big picture of what's happening for them across ADLs and all those other things. So Q3, we just got our attribution information. Again, we saw another good jump of 125 patients and just continuing to expect more and more. I expect at some point we'll probably top out a little bit. So probably Q4, maybe. I don't know. We'll have to see. But I'm excited about the progress that they have made, and they have just really worked hard, and they have really engaged with that quality improvement process. Does this work versus that? What makes the most sense? How do we contact patients? What are the providers doing? How does it fit into their workflow? So they're to be congratulated. I feel like they are a fantastic story, but definitely doable. It's just being committed to improvement. So don't forget, as much as they're making more revenue associated with the APM, they're also getting, the money associated with fee for service for those annual wellness visits. So, again, not an insubstantial amount of money. It also, gave them a little more flexibility to potentially add a part-time provider to really just deliver AWVs, or, to pick up some of the patients to allow there to be more wiggle room for the providers who were already there. So I think it's really important to think through, if there's no, money to go around, as ugly as it is to talk about, we can't deliver a service if we don't have a revenue source. So as ugly as that is, it is a reality. Annual wellness visits, we like to, when I start consulting, we like to look at your historical wellness visit rate. If you're doing this for an organization on your own, take a look. Who's doing this really well? Who's not doing this so well? Are they not doing it well because they don't have the right staff? Or is it that they don't understand? Or they just don't have a process in place to make that happen? You want to take a look at their attribution list. Do those patients make sense? Do they really belong to somebody else? Are you looking at a cardiologist and you really need to look at, whether the patient is attributed to primary care? Also, you need to look at the patients that are not attributed. So are you able to compare those lists? Who are the patients that, oh, wow, you know what, we've seen them 3 times in the last 9 months, so it looks like they should belong to us. I wonder where they are attributed. What's happening? Where are they? My personal story, my husband had some health complications and ended up getting attributed to his cardiologist because that's who he was working with. That's who he was seeing on a regular cadence for 6 months, right? His primary care had absolutely referred him, but he ended up attributed to the wrong place. Really at no fault of his own. So super interesting. What are you doing with new patients, right? You don't have time to get plurality. Do you really want to wait 2 years into a program, or 18 months or a whole year? Is there methodology that will get them attributed faster? What is that process? What does it look like for your team? When was their last AWV? Was there a last AWV with a previous provider? Some organizations have found that insurance companies delivered the last AWV. I'm here in Utah, and we have wellness vans that kind of move from community to community, and they'll send out flyers to all of their members, and then the people can come to this little, looks like a motorhome essentially, and they could get their wellness visit delivered by whoever happens to be in that van. Definitely not what Medicare thought would happen. And there might be some benefits to it. I can kind of see both sides, but I lean more to, use that wellness visit to really continue to build that relationship with the patient. When are they eligible? You want to get paid for a service. And if the difference is 3 days, it really doesn't matter to the patient, but it will matter to your revenue stream. Workflow. Workflow always drives challenges and certainly can give you some heartburn. That's maybe the easiest way to put it. Are you using a current process? Have you maximized it? Is everybody on the same page? Do they know why they're doing something? I'm a big why asker. Why are we doing this? So you may have folks like that on your team. Do they need a little more support? Do they need something that reminds them? Do they need another person to help them to do that? Is there a way that you could do that training? Review achievements. People need to recognize when they have done something really, really well. We like that kind of feedback. And especially if we're going to review where are our opportunities, where are we falling short a little bit, I think it's a great thing to recognize this is where we've come from, this is where we're going. So don't hesitate to tell your team what they're doing well. Make changes. I am, again, I come from a quality improvement experience, and if you're not making a change somewhere, you're probably dead. So be open to changes. Help your team to recognize that change is a part of your practice. A lot of practices that I've been in, when I first started, change was painful, and change meant somebody had done something wrong. And you don't want that kind of feeling in your practice. So, introducing this change, introducing opportunities for improvement as change gives people a better feeling about those changes. So start again, try again. None of us are perfect. The few of us that are perfect, they don't live very long. So we really just want to be sure that we're communicating with our teams that change is a good thing. Change is a part of the practice. Change is a part of improvement. So super important overall. So this again is another table with a bunch of numbers. You're like, I don't know, don't care what it means. So I did some calculations in Excel. Could be the back of a napkin, whatever. Again, this is a primary care first example. The per beneficiary per month amount is listed in that center column, and the break even with visits. So is how many times you need to see a patient in the year to make it more financially beneficial to keep them in fee for service versus getting them into the APM. So if I have a new patient and they're not attributed, I need to see them 6 times per year to make it more financially viable for me versus getting them enrolled, versus getting them attributed. So that's a lot. That's a lot of times to see a patient, particularly a new patient. Some of our new patients are really healthy, which is great, but some are not. In a group 2 practice, so this is, they're getting a $45 per beneficiary per month. I would need to see that patient 10 times per year as a provider, so that fee for service would allow me to break even. Some of you are thinking at this point, well, what kinds of calculations did you use? So the assumptions are just listed there at the bottom. Again, just used some primary care first numbers to give you an idea. Certainly, these are not difficult calculations. It's just a matter of kind of thinking through it, figuring out where is your break even. Does attribution make sense? Should you invest time and effort in that? So in my line of thinking, this slide really gives you the opportunity to think through, is attribution something that I'm focused on? If it's not, maybe instead I need to focus on the number of times I'm going to see that patient. But 21 times in a year, I can pretty well guarantee you patients are going to tell you, no, I'm not going to do that, unless there is a really, really good reason. I'm trying to think. I probably go to the grocery store 21 times in a year. Pretty sure maybe double that. But if I have to go a whole lot more than that to somewhere else, I'm not doing it. I just won't. I'm a bad patient, apparently. When we start attribution planning, again, some more things to think through. Certainly, these may not be the only questions, but I think it's a really great place to start. Who are the patients that are eligible? So who are the unattributed patients? How are you identifying them? Are you scheduling an annual wellness visit? Maybe they need chronic care management if that's the attribution methodology. If there's another attribution methodology that works in your program for your patients, fantastic. How are you going to risk evaluate? All of these programs are focused on cost and what cost avoidance we can have. Well, the best way to avoid cost is to identify risk in advance, right? So how are we doing that? Are you looking at risk? What are the risks? Most of us know the risk for a lot of geriatrics, things like falls, right? Exacerbation of their chronic health condition, okay? Accidents, less likely, maybe diseases that we could have prevented with immunization. Those are some really preventable things. Also access to care. So, none of us want our 73-year-old grandfather going to the emergency room for management of his blood pressure, right? That doesn't make any sense because honestly, the ED providers really don't care unless he's going to stroke. So we just need to make sure that that individual, that patient understands what happens if my blood pressure is high. Who do I call? What do I do? What are the signs that I need to go to the emergency room? So I call them the if-thens. If this happens, then what do I do? So really dealing with those. Establish and update a care plan. So when I was a new pharmacist, we had a discussion about care plans and what patients were supposed to do, and medication challenges are a part of care plans. And one of my patients had been using Spiriva, which is it comes in a capsule. It has to be broken and then inhaled, and they were swallowing the capsule instead of inhaling it. Well, they were absolutely using it every day, but it absolutely was not working. And so what is that care plan? Who's going to review it? Who's going to update it? Thank goodness we caught it. They eventually started inhaling the Spiriva instead of swallowing it. But what are the surprises that come up with patients? How are you identifying them? Maximizing their HCC risk score, making sure that their problem lists are clean, and that what is actually happening for that patient is what you have in the chart. That is your source of truth. Patients need advanced directives. I'm a firm believer in advanced directives, and my advanced directives are kept in the jockey box of my car, the glove compartment. Nobody wants to try to figure out my filing system, I'll be honest. Thinking through what is historical use. Historical use of care really will predict what patients are going to do next. So if my 73-year-old man with high blood pressure has been historically going to the ED for management of his hypertension, what intervention do we need to make to stop that? Because if I don't do anything, chances are he's going to keep going back there because at least somebody's paying attention. And then how do we scale? How do we scale to all patients? How do we scale to CMS patients? What does that need to look like? And how does that impact the kind of care we're giving? This just really speaks to quality improvement and quality improvement strategy. Taking a look at data, monitoring and measuring your performance, prioritizing. It may be that you have to prioritize a different area and you back up and try again. just really depends on, on your organization, your practice. What does that look like? What do those people in the practice look like? Are they interested in change? Are they driven by data? Or is it, a lot of us in healthcare are driven by what we feel. We want to say it's the data, but often we're driven by, well, I feel like this patient could benefit from this. So we have some interesting challenges in healthcare. So just to summarize some challenges succeeding really in primary care first or any advanced payment methodology, understanding attribution. Who are you missing? Who have you got? Do you have the right staff? So often I hear from practices where, yeah, I have a care coordinator, but that person gets pulled to do nursing or MA duties if somebody calls in sick. Well, and I absolutely understand 100%, but does it make sense for what your long-term goals are? Maybe not, maybe yes, depends on you. Again, using effective tools. You can absolutely use a hammer to open a window. Do you spend time with the right patients, the right amount? Are you having the right discussions? Are you having a hypertension discussion with our 73-year-old guy, but it doesn't involve a discussion about the emergency room use? I don't know. Some questions to think through. Are there patients who have complex needs? Okay, what else do they need? How else can you reach them? How else can you help to manage them? Quality data. Data is just a bunch of numbers until there's some sort of meaning attached to that. So how are you using the data? What does it mean to you? And then optimizing staff, skill sets, time, resources. We all have very limited time and resources. We have limited staff. We just have to do with what we have. So how are we going to maximize that? This is just talks about how important it is to have a partner for value-based care, creating plans, analyzing and improving scores, looking at your quality, really doing the consulting work that is necessary. So I'm going to kick this back to Charles. If you have questions, please feel free to ask away. I think I've talked more than enough, and would love to hear what you're thinking and what makes sense to you. So Charles, back to you.
Wonderful. Thank you so much, Roxanne, for that dive into the case study and the attribution challenge. We do have a quick poll here, wondering to understand, in your organization and your practice, is attribution a challenge, and managing, the status of that. So I'd love for folks to please take a few minutes, a few seconds, we'll say seconds, we're not going to wait here for minutes, just to give us a little bit of insight into if this is a struggle for you or if things are going pretty smoothly. And we do have some great questions too on fine-tuning some attribution questions, so we're going to dive into those momentarily. After you've answered, please feel free to get your questions in. We've got plenty of time here to go through. All right, thank you. All right, and not quite surprising, I think, based on the topic and our experience, is that folks are finding, definitely finding it somewhat challenging is the winner there. Some are very challenging, and some seem to be finding their way without too many bumps, which is great to hear.
Yeah, I'd love to hear more from them too. If you're not having challenges, did any of this resonate for you? Are there things that have been really successful? Yeah, I'd love to hear how they're doing really well too.
Yeah, so please, if you'd like to, feel free to pop in the chat if you'd like to share any of your experience. We'd also love to hear that as well. We can unmute you if you're willing. or you can just put it into the chat and we'll share it back to the audience. All right, so our first question is from Karen. Where do I find a list of attributed patients?
I'm assuming your list of attributed patients you're talking about for primary care first, and that is on the CMS web portal. So if you go into your data information, particularly in primary care first, I think it's the last tab at the top, and it says patient attribution. If you click on that, scroll all the way to the bottom, that's where that is. Great question. It's hard to find. CMS has weird ways to find stuff.
I mean, we found that just making sense of the data that's being provided to you to help you succeed in these models, just finding it and then figuring out how to analyze it is one of the barriers to finding success in these programs.
Mm-hmm.
Our next question is from Emily. We've noticed a discrepancy between our patients on our panels and patients being attributed to PCF. Many of them have had AWVs, but are not attributed to PCF. Any insights on that?
We've had a few of those. One thing that we noticed was we were looking for them too quick. So remember, you have that 1 quarter lag period. If there was one patient that we absolutely couldn't figure out, like, how did they get missed? So we sent a question, said, hey, can you take a look at, we would really like to look at a particular patient. Can you call me? Of course, don't send patient names, dates of birth, don't send PHIN email, not endorsing that. But see if you can have a conversation with someone at the PCF office. Had a great discussion. They were incredibly helpful, and did some research and gave us a not fabulous answer, but it was an answer nonetheless. So that may be something, take an example or two, reach out to them, talk to somebody there at the PCF offices.
Absolutely. It sounds like they've submitted some questions, so we'll see what they hear back. But please do feel free to reach out to Roxanne or to any of us for some assistance interpreting what comes back.
Sometimes it's not quite an answer. I don't know if anybody's had that experience. You submit a question and you kind of get an answer, but mostly not.
All right, our next question that we have is from Amy, is can you break down a little bit the break-even information?
Yeah, sure.
For example, like what's the total cost included, et cetera, in the calculation. So I don't know if you want to pick one of those examples, Roxanne.
Yeah, let me go back. Let me see if I can find the right slide. Hold on, we'll return. I know, sorry, close your eyes. Okay, here we go. So some of my assumptions we can take a look at. If this is not the slide you're referring to, please jump in, tell me this is not what I'm looking for. Some assumptions that I made were that a fee-for-service visit was a $95 payment from CMS and $18.50 for the copay. Then the $28 per beneficiary per month. And I looked at it as if I have a patient enrolled for a year versus in fee for service. So what are the total amounts? So the $40, the $41 per visit is specific to primary care first. I believe it's $40.82, plus the patient would still have their traditional copay. So for purposes of the calculation, you could drop the copay entirely. But I set it so that I wanted to know what was the 100% mark. Where was it? Where were we getting, as far as a practice, the same amount of money from CMS in visits versus the per beneficiary per month plus the visit payments. So that's how I set it up. The per beneficiary per month obviously changed each time. And let me see if I've got, I may have, I'm gonna stop sharing my screen for just a second so I can find a different thing that I can show you. Sorry, Excel, here we go. All right, I'm gonna show you the screen again. So sorry. Maybe. Okay, you should be seeing the calculator, basically my Excel spreadsheet. Please do not judge me based on my use of Excel. Not bad, but it, anyway. This site, you can change the number of patients. Obviously, it changes the numbers, the PCF visit amount, the tier, per beneficiary per month, their quarterly revenue, annual revenue based on the number of visits per year. So if I change that, you can change lots of things in here, get a better idea of adjusting. Maybe your average reimbursement is closer to 135, right? I don't know. Let's see, maybe 20 visits per year. Yeah, that gets you pretty close. And again, I'm just comparing dollars to dollars, not dollars to effort or anything like that. But that at least gives you an idea.
Great.
Amy, please let me know if that didn't answer your question. I'm happy to try again, or we can even.
She wrote in and said that it definitely helped. So.
Okay, good. If not, I'm happy to take it offline and we can drill in deeper. So happy to do that too.
All right, our next question, before we get into our next question, just a time check here. We've got about 7 minutes. So if you have anything on the tip of your tongue or in your head, go ahead and plop it in the chat there, please, because we'd love to get to your question if we can. Just a reminder, this webinar was recorded, so the slides and recording are going to be sent out later this week to all of you. And we invite you to visit minglehealth.com, reach out to Roxanne directly or through the live chat. Our team of experts they're always behind the scenes there waiting to hear from all of you. So
I like getting emails.
Yeah.
It's crazy, but I like getting emails.
All right, so our next question is from Karen. I have noticed that MCOs are doing AWV and CCM for our patients, which is okay, but I'd like for us to start doing them now. Who gets priority, them or us?
So managed care organizations are definitely looking to step in because it's their money, right? So if it's not happening, fine. And with regard to priority, that is going to depend on the MCO, first of all, but they really want you to do it. You have more visibility into the patient. You have that care relationship. So I have never found an MCO that didn't encourage the practice to provide that care management or AWV. It's just if they tend to make it easy and convenient for patients, and they have had the resources to build out programs. And so, reach out to the representative of the MCO, find out what they have to say, but otherwise get started. If you're providing care management, they will pay for it. If you're providing the AWV, as long as it hasn't already been done, again, they'll pay for it. So if you need an eligibility list or who is left to be done, reach out, because most MCOs want you to succeed. They want their patients taken care of, and there's no better environment than your practice. Great question. Thank you.
Great question. Thank you, Karen. All right. That does it for all of our questions. Any final reminders, Roxanne, about the program or the opportunity that you want to share with everyone?
Quick reminder, remember to update your provider list on the portal. That needs to be done here soon. Great job getting your patient rosters in. That was a bit of a scramble, for many of us, and getting that information. And then remember too, we are now more than halfway through the year. If you don't know where you're performing on the measures you're going to have to submit, hurry up, get on the stick, because it's hard to make changes and to correct a direction if you have to. So definitely you want to take a look at where you're at. That's going to be critical. So if you don't already have a registry where you're looking at advanced care planning, hurry up. We're seeing a lot of our clients, we have a lot of great data, and we're sharing a lot of great analytics. So don't hesitate. We have time, we have resources. We want to talk to you, and we want to get you the insight and the help that you need when you need it.
It's a great reminder. Thank you, Roxanne, and thank you all. Mingle Health, as we said, we are a qualified registry, and so we do stand ready to help you succeed in primary care first, in APMs generally, and also MIPS. It is halfway through the year, and our consultants, like we said, we have this unique combination of technology and expertise, and we are right now reminding our clients, where's your performance at? What measures are you reporting? What gaps do you think you can close? Is it a data issue? Is it a care issue, a workflow issue? This is your opportunity now throughout the year to be making changes and understand where your performance is falling within the different benchmarks. So we stand ready to help you, and please do reach out with questions so we can be a resource to you. Thank you all for joining us today, and hope you have a wonderful rest of your day.
Thanks, everyone. I appreciate your time. Have a good day.